Alright guys, this is Dr. Manish Chabra, your ophthalmology educator. Now in this video, I am going to discuss INICET November 2025 exam questions. Now I know that you have got to know the answers, you have checked it by your own self. So the idea of having this video is not to actually tell the answers in a very quick fashion. The idea is to give you concepts so that your juniors who are going to appear for INICET next time, as well as those who are going to appear for NEET PG 2026. It may be you as well, right? So you people have to see this video once so that you are going to connect the dots pretty well. And since there is always a high probability of previous year questions or at least previous year topics, so I really don't want all of you guys to miss that. So with that thought in mind, so I am going to discuss these questions in a little detail, है ना? सो आइडिया ये रहेगा कि इस वीडियो के बाद हर कोई, चाहे आप थर्ड ईयर के स्टूडेंट हैं, चाहे आप इंटर्न हैं, चाहे आप पीजी एस्पिरेंट हैं, चाहे आप एफएमजी एस्पिरेंट हैं, आप कुछ ना कुछ ज़रूर सीखें. देयर इज गोइंग टू बी समथिंग फॉर एवरीवन, राइट? So starting with the very first question, that is Krukenberg spindle is seen in which of the following conditions? Now whenever such question comes, so it appears to be a single liner, but there is a lot of concept which is hidden behind this. So what is your Krukenberg spindle? So Krukenberg spindle is the pigment deposition on the corneal endothelium, right? Now the point is how the pigment is coming. Do you see pigment in angle closure, acute angle closure glaucoma? So I got two options. Some students told that it was malignant glaucoma, other students told that it was acute angle closure glaucoma, while other three options, which is pigmentary glaucoma, juvenile open angle glaucoma, primary open angle glaucoma, they were confirmed, right? So do you see Krukenberg spindle? That means pigment deposition on the endothelium of the cornea. So these are the options. So first and foremost, let's look out for pigment deposition. So boys and girls, this is your pigment deposition on the corneal endothelium. Right now, what happens in one particular type of glaucoma? The name of that glaucoma is pigmentary glaucoma. Some students even told me that it was not pigmentary glaucoma, it was pigment dispersion syndrome. So pigment dispersion syndrome, the patients in which there is PDS, pigment dispersion syndrome, they actually develop pigmentary glaucoma. Now can you tell me what is the definition of glaucoma? First of all, I know there's a lot of confusion, especially amongst third year students. So what is glaucoma? Don't take glaucoma as synonymous to raised IOP. If you'll say, okay, you are having raised IOP, so you are having glaucoma. No, not at all. There's a proper criteria of glaucoma. Any two, minimum 2 out of 3 should be present. What are those 3 points? One is your raised IOP. Second is there should be visual field changes. Third is OCT RNFL changes, or you can say retinal nerve fiber changes, or optic nerve head changes. In a better way, I can say optic nerve head changes. You know na, what are those optic nerve head changes? There is increased CD ratio, there is bayoneting sign, there is nasalization, there is laminar dot sign, there may be presence of peripapillary hemorrhages, more specifically in normotensive glaucoma. So any 2 out of 3 should be present if you would say that this is a case of glaucoma. But if there is just the pigment not causing visual field change or optic nerve head change, then you will call it as pigment dispersion syndrome. Even if it is causing raised intraocular pressure, you will call it as pigment dispersion syndrome. If it is causing raised intraocular pressure or any of these two, visual field changes or optic nerve changes, then you will call it as pigmentary glaucoma. Okay, so of course Krukenberg spindle, it is seen in pigment dispersion syndrome or pigmentary glaucoma. That means pigment dispersion syndrome has led to raised intraocular pressure, which has further led to optic nerve head changes or visual field changes, right? But we need to eliminate each option one by one. What is juvenile open angle glaucoma, boys and girls? Can you tell me the age limit? So we divide the primary glaucoma into three parts. One is PCG, which is primary congenital glaucoma, 0 to 3 years of age. Then there is juvenile open angle glaucoma, which is 3 to 16. No, 3 to 40 years of age. Then we have got adult glaucoma, which is more than 40 years of age. Under adult glaucoma, there is primary open angle glaucoma and there is primary angle closure glaucoma, right? Now you are clear. So we know about primary open angle glaucoma. Juvenile open angle glaucoma is similar to primary open angle glaucoma, just that there is a age difference, right? So primary open angle glaucoma, juvenile open angle glaucoma, they are eliminated. We haven't heard about Krukenberg spindle. Now what about acute angle closure glaucoma? You will say, sir, we have heard about some pigment in acute angle closure glaucoma. Boys and girls, that is your vogued triad, which actually tells about the previous attack of angle closure glaucoma. There is glaucoma fleccens. These are anterior lenticular opacities. Second is pupillary sphincter atrophy. Okay, sphincter atrophy. And third is pigment dispersion on anterior lens capsule. Right? So this is different from that of your Krukenberg spindle. So acute angle closure glaucoma is eliminated. Malignant glaucoma. So malignant glaucoma, there is formation of vitreous pockets which pushes the iris lens diaphragm forward. Wait, I am going to show you the images. First and foremost, let's see the Krukenberg spindle. So you can appreciate there is Krukenberg spindle. Now what happens in pigment dispersion syndrome? What is abnormal in that? Mind you, normal iris configuration is, what is this? Convex anteriorly, right? But in some patients it become concave anteriorly. So whenever there is pupillary dilatation, constriction, maybe a young male who is doing a lot of exercise, because of a lot of effort, there is sympathetic system innervation. So sympathetic system will cause dilatation of the pupil. So continuous rubbing of the iris on the lens or zonules will lead to pigment dispersion. Why it can lead to pigment dispersion? Can you appreciate the 4 layers of the iris from anterior to posterior? There is anterior limiting layer, then there is stroma, then there is anterior non-pigment epithelium, 4th layer from anteriorly. That means the posteriorly, it is posteriorly pigment epithelium. Because there is posterior pigment epithelium rubbing upon lens and zonules, it will lead to pigment dispersion, which will settle in the trabecular meshwork, which will stop or slow down the flow of aqueous humor from the anterior chamber to canal of stem via trabecular meshwork. As a result, it will raise the intraocular pressure, which will put the pressure on the optic nerve, which will cause optic nerve changes as well as visual field defect. So here you can appreciate that there is concave configuration of the iris. Okay, if we are doing pigmentary glaucoma, we should touch one more important point. What is this? This is a gonioscopic view of the angle of anterior chamber, and you can appreciate that there is deep dark pigmentation on the angle of anterior chamber, and that is at the trabecular meshwork due to pigment dispersion. Boys and girls, this is known as your Sempo-Lacy line. If pigmentary glaucoma, Krukenberg syndrome can be asked, Sempo-Lacy line can also be asked, mind you. All right. Now, because of the constant rubbing, there is pigment dispersion. There can be trans illumination defects, because now the pigment has been released. So when the light enters into the eye through the pupil, it will strike the retina, and you know there is red reflex. When the light will be reflected back, it will not only come from the center but also from the points where there is absence of pigment. This is your trans illumination defects, which is seen in pigmentary dispersion syndrome. Okay, all right, now there is another image which I have put. So there is misdirection of the aqueous humor. Why? Because there is back rotation of the ciliary processes which secrete the aqueous humor. Aqueous humor is secreted by non-pigmented epithelial cells of pars plicata of ciliary body, right? So when there is reverse direction, so it starts dumping aqueous humor in the vitreous, such that there is formation of aqueous humor pockets in the vitreous humor. So as a result, there is raised intra which pressure, intra posterior segment, intra vitreous pressure, which pushes the iris lens diaphragm anteriorly, leading to collapse of the anterior chamber, and it is known as malignant glaucoma. The pressure is very high, so it is also known as inverse glaucoma. This is your previous year question, last year an INICET question. This is inverse glaucoma. And what is the treatment of choice in inverse glaucoma? The only treatment which you give in inverse glaucoma, medical treatment in the beginning, is atropine. Now you'll say, sir, atropine? We haven't heard about atropine to be given in any of the glaucoma. Yes, this is the only glaucoma where you will give atropine, because it is going to dilate the pupil, which is going to push back the iris lens diaphragm, which may correct the problem, correct the misdirection of the tips of the ciliary processes, right? And if with atropine it is not corrected, then you go on for surgery. Surgeries, you make a hole in the iris, you make hole in the zonules, and you take out a part of the vitreous humor. As a result, you call it as irido, hole in the iris; zonulo, hole in the zonule; hyaloid, word is used for vitreous humor; dectomy. So by making hole in the iris and zonules, you take out the vitreous humor in which there are aqueous humor pockets, and eventually the disease is fine. So this is the surgical management: irido, zonulo, hyaloidectomy. This is, boys and girls, your malignant glaucoma. But we know the answer. The answer is pigmentary glaucoma or pigment dispersion syndrome, whichever would have been the answer. Please let me know how many of you got this correct. So it appeared to be a single liner, but it was not actually a single liner. There was a lot of concept which was involved behind this question. All right, now a patient presents with sudden onset severe eye pain, headache, blurred vision, and colored halos. Okay, now examination reveals a mid-dilated pupil. So these are all keywords, boys and girls: steamy cornea and very high pressure, which is 60 millimeter of mercury. What is the most likely diagnosis? So we are going to eliminate the options one by one. So if we take Phacomorphic, if we take first, which is secondary angle closure due to anterior uveitis. So what happens in anterior uveitis? What can be present? So headache can be present. Yes, headache can be present. Blur vision can be present. Yes, blur vision can be present. Uveitis can lead to sudden painful loss of vision. Colored halos can be present. No, boys and girls, colored halos cannot be present in anterior uveitis. Okay, now examination reveals mid-dilated pupil. What about the pupil status in the anterior uveitis? Pupil is typically constricted and non-reacting, constricted, non-reacting, or it may even be irregular due to presence of posterior synecdoche. Remember, festooned pupil. So steamy cornea can be there. How? If there are keratic precipitates which are sticking behind the cornea, and it may give cornea some sort of a hazy appearance, right? Let me show you. As you always say, अगर आपने OPD में patient नहीं देखा तो क्या देखा? Once you will see the patient, you will always and always remember it for the rest of your life. So this is your mutton fat K piece. Check out the status of the cornea. So cornea will appear a little bit hazy. Why? Because of the presence of keratic precipitates. Can you appreciate the keratic precipitates which are present at the lower one-third of the cornea, forming a vertical base down triangle? That is your Arl's triangle. Okay, so sometimes due to intense anterior uveitis, intense inflammation inside the anterior chamber, there can be some corneal edema which may be present as well. In this patient, there is no corneal edema, but you can actually see the keratic precipitates. But can you tell me what is the earliest feature of anterior uveitis? बता पाएंगे? What is the earliest feature of anterior uveitis? I am going to show you one video which you may have never seen. This is, boys and girls, your earliest diagnostic feature of anterior uveitis. Check out carefully. What do you see in the black region in between the cornea and the iris? What do you see? That is the cells in the anterior chamber. If there is cells in the anterior chamber, you have to mark cells in the anterior chamber. Cells in the anterior chamber not in the option, go for proteins in the anterior chamber. Now I am increasing the magnification and you can actually see the cells floating in the anterior chamber. I am again repeating, to the earliest diagnostic feature of your anterior uveitis. Okay, all right, all right, all right. And you can see the pupil is constricted. However, there are no synecdoche, there is no irregularity, but pupil was constricted. You saw it yourself. Now see, the questions are not just meant for kind of asking you in the form of theory. So whenever they ask you questions, they believe that you have seen that patient. And I understand ophthalmology is one subject which we are not exposed to much, but don't worry, it is my responsibility, it is your I coach's responsibility to teach you ophthalmology in a very clinical, conceptual and a concise manner. And I am also going to take you to my OPD, main OT, minor OT, and we'll be doing a lot of procedures so that you have a feeling of being with me, you have a feeling of having seen all the possible cases that can be asked, and it will be of help to you while treating the patient as well. Okay, so anterior uveitis is removed, anterior uveitis is removed. Now coming over to your neovascular glaucoma. If we talk about neovascularization, what happens in neovascularization? There is bunch of vessels which is present on the surface of the iris. There are bunch of vessels which may even go up to the angle of the anterior chamber. So there is fibrovascular membrane which is formed, and this fibrovascular membrane contracts, collapsing the angle of anterior chamber, right? And so based on the sudden onset, severe eye pain, headache, blurred vision, colored halos, they are not at all associated with neovascular glaucoma. Of course, the pressure may be high. Yes, it may be high, but the pupil will be mid-dilated or dilated. Yes, of course, that is also there. But steamy cornea can also be there. But the other features, sudden onset severe pain, headache, blurred vision, colored halos, it eliminates neovascular glaucoma. Of course, if they were thinking of taking you towards neovascular glaucoma, they would have given you some more clues. Patient is diabetic, patient is having proliferative diabetic retinopathy. On examination, the iris appears neovascular rubeosis, iridis. Just a moment, I am going to show you one another interesting video so that you remember this, because sometimes what you see and it can come in your exam and there will be your win-win on seeing that question. Let me show you the iris neovascularization. You will yourself see. Check out the vessels which are present on the iris, and check out the pupil is mid dilated, है ना? So pupil is mid dilated, probably due to sustained raised intraocular pressure. The optic nerve head is gone, so that is why pupil is not reacting to light. This patient had come to me in PGI and he had PL negative. He had gone PL negative due to raised intraocular pressure. He did not know that he had developed glaucoma, but when I examined, I could actually see the vessels, and I made the diagnosis of neovascular glaucoma, leading to total loss of vision, leading to absolute blindness, leading to PL negative. Okay, and what about phacomorphic glaucoma? Phacomorphic glaucoma, when there is swelling of the lens, the periphery part of the lens, actually the lens or the entire lens shifted the peripheral part of the iris anteriorly, collapsing the angle of anterior chamber. And in this case, you actually see the milky white lens, or the lens may be intumescent, so there may be cataractous changes in the lens. Yes, and second is the pupil will be mid dilated. Taken, yes, the pupil will be mid dilated. But the other features: acute onset sudden eye pain, headache, blurred vision, colored halos. Blurred vision will be there, okay. Colored halos, no, it will not be there. It may be associated with steamy cornea, but this acute onset sudden eye pain, it eliminates the phacomorphic glaucoma as well. If the examiner was to take you towards phacomorphic glaucoma, the examiner would say that the patient is having cataract, or maybe would kind of mention that the lens is pearly white in color, which will make you think on the grounds of mature cataract, and mature cataract can lead to phacomorphic glaucoma. Okay, so here you can appreciate this is your festooned pupil, which is seen in acute anterior uveitis. This is your mid-dilated pupil, and you can see the cataractous lens, and this is your rubeosis iridis. Yes, you can actually see rubeosis iridis, so you can actually see neovascularization. We have seen the video itself, but here you can see the steamy cornea, mid-dilated pupil, and because of the steamy cornea, the hazy cornea, so the patient may complain of halos. Mind you, there is one test. This is your PYQ. How do you differentiate between the halos of cataract and halos of glaucoma? By a very common test. It is your Fincham's test. This question was asked to you in your FMG exam, and it was also asked in your NEET PG exam, so it is very important. Fincham's test. Okay, so the answer is your acute primary angle closure glaucoma. I again repeat, it is acute primary angle closure glaucoma. There is sudden painful loss of vision, mind you, but this painful loss of vision is not due to optic nerve head changes or due to visual field changes. This is due to steamy cornea because of the sudden raised intraocular pressure, which ruptures the Descemet's membrane, which leads to aqueous humor coming into the cornea, leading to very hazy cornea, right? So this is your acute congestive stage of glaucoma, right? And that was the answer. I hope you have understood, right? So I'm not writing much because I want to make this video very conceptual, and you can anytime go back 10 seconds, 20 seconds, 30 seconds, and you can listen to me again if you have missed something. And I want you to take notes as well. Just take a register, write INICET November 2025, and take note of all the points that I am telling you. These are all PYQs or PYTs, nothing more, nothing less than that. Okay, all right, now coming on to the next question. A patient with miosis, okay, ptosis, anhidrosis presented to the clinic. Which structure is most likely compressed in such a scenario? So it may appear to be a single liner, but boys and girls, it is not a single liner. So if the patient is having miosis, means pupillary constriction, ptosis means drooping of the eyelid, and anhidrosis, probably the examiner wants us to think on the ground of Horner syndrome. So there are 4 parts in the Horner syndrome. One is miosis, ptosis, anhidrosis, and enophthalmos. But since this is your INICET exam, so they have taken it a little higher. But if it had been FMG exam, because FMG exam, NEET PG exam, they would not go up to this level, so they will restrict themselves to the basics of Horner syndrome. Because this is INICET, they have taken it to the other level. So what is that level? So they are asking about Horner syndrome. But so of course Horner syndrome is oculosympathetic paralysis. So there is paralysis, there is damage to the sympathetic fibers, right? So vagus nerve is eliminated, abducens nerve is eliminated. Now we are left with first and second option. Now first and second option both can cause Horner syndrome, but before that let's understand the Horner's pathway. So there is, from hypothalamus, there are sympathetic fibers that go till C8 and T1. This is your central fibers. Then from there is another fiber which moves between the clavicle and the tip of the lung and comes towards the inferior cervical ganglion, then towards the superior cervical ganglion. So these are your central fibers. These are your preganglionic fibers, which are coming from C8, T1 or T2 to the superior cervical ganglion. But here they are post ganglionic fibers which loop around the internal carotid artery and enters into the middle cranial cavity, and they further enter into the orbit and ultimately supply dilator pupillae. Okay, now we know the first and second option goes with Horner syndrome, because if there is any compression in the central sympathetic chain, then also there will be Horner syndrome. If there is any compression, any damage to the sympathetic plexus which is looping around the internal carotid artery, that will also be your Horner syndrome. But based on one clue, we can actually know what is the final answer. That clue, boys and girls, is your anhidrosis. Now you'll say, sir, anhidrosis, how come anhidrosis? There is one concept which is involved. That concept says that the fibers which supply the glands of the face, which causes sweating of the face, they don't go via post ganglionic fibers. They will come from here, they will not go via post ganglion. So that actually tells me, if they are saying of anhidrosis, that means the lesion is somewhere between the posterior hypothalamus until the superior cervical ganglion, because from here the fibers reach up to the face and supply the glands, right? So that the sweating can be done. But there is anhidrosis. Anhidrosis says that there is damage, so the damage is from here till here. Had there been post ganglionic Horner syndrome, there would not have been anhidrosis. So now you know the answer, because I told you that ICA, internal carotid artery, starts the sympathetic plexus loops around internal carotid artery in the post ganglionic phase, so it is eliminated. So the answer is cervical sympathetic chain. I believe I would rate this question on a difficulty level from 1 to 10 is 9.5. It is that difficult, because these two things, of course there are concepts, but based on the anhidrosis point, which is often left by the students, है ना? So I would rate this question as one of the most difficult questions. Okay, now moving over to the next question. Okay, a 36-year-old patient with history of chronic rubbing and high myopia, okay, along with astigmatism, presented with sudden painless loss of vision in one eye. So chronic rubbing, high myopia, astigmatism. Which direction are we going? So probably the patient is chronic allergic. The patient will keep on rubbing, and constant rubbing can lead to one important complication, that is your keratoconus. Mind you, keratoconus. So that is why in vernal keratoconjunctivitis, which is a bilateral condition, keratoconus is common if the patient keeps on rubbing. I usually show a patient of keratoconus in my class as well, and I tell you the history that this young girl was having allergy which is more in summers, and she kept rubbing her eyes, which led to development of keratoconus. So she has a history of frequent change of glasses earlier because of irregular astigmatism, so she needs to constantly get her refraction done and corrected as well. Visual acuity is reduced to perception of light. Slit lamp image is shown below. The image of procedure is provided. Okay, so what do you feel, what is done? So basically they want to know which procedure has done. Now what are the treatment modalities in keratoconus? So one treatment modality is rigid gas permeable contact lenses, in which cellulose acetate butyrate material is used, your PYQ. Second is most commonly used is C3R, which is corneal collagen cross-linking with riboflavin. So you can see an air bubble in the anterior chamber. So do you see air bubble in the anterior chamber in any rigid gas permeable contact lenses? No, not at all. That is also not in the option. Do you see air bubble in C3R technique? No, we don't enter in the anterior chamber only. So this option is eliminated. Mind you guys, even if you don't know anything, still you can try reaching up to the answer. So in INICET, it is very important to go for maximum educated guesses, because the seats are very limited. So if you are attempting less, you are already out of the league. So why not to take chance? and try to be back in the league. So one option is eliminated. Now there is 33% chance of getting correct. I believe even if you are able to eliminate two options, you should definitely take a chance. Okay, now what is DSAC and DALK? DALK is your deep anterior lamellar keratoplasty. DSAC is Descemet stripping automated endothelial keratoplasty. Right now, in deep anterior lamellated keratoplasty, that means, what does it say? That this is the cornea, this is the cornea. Okay, now if there is any opacity here in the cornea, so what you do, you take this part of the cornea out and you take a graft cornea, and you cut this part of graft cornea and you put it here. Yes, and then suture it. So that is your deep anterior lamellar keratoplasty. Now, do you think that any bubble would be put in deep anterior lamellar keratoplasty? क्या लग रहा है आपको? deep anterior lamellar keratoplasty में कोई बबल डालेंगे? इसमें तो हम एंटर ही नहीं कर रहे हैं. We are not entering into the anterior chamber. So DALK is also eliminated. Now we are left with two options, DSAC and intracameral. Guys, I am telling you, even if you are not aware of the question based on your other topics, based on your educated guesses, you can still mark it. Now you have a clear cut option of 50% of getting this question correct. Now what is DSAEK? Descemet stripping automated endothelial keratoplasty. Now you tell me why you would go on for Descemet stripping automated endothelial keratoplasty. Why would you go on for keratoplasty there and then? What is the indication of keratoplasty in this case? Of course, you will go on for Descemet stripping automated endothelial keratoplasty if there is any endothelium defect, right? So this is one. Let's keep it as standby. What is the use of intracameral C3F8 gas injection? Why would you give any gas? Why would you leave any gas bubble? First tell me, where have you read C3F8? Is there any other topic where you have read C3F8? Could you recall? अच्छा चलो ये बता दो, आपने कहीं SF6 पढ़े? What is SF6? That is sulfur hexafluoride. याद आया? याद आया? याद आ गया. SF6 you have read in your retinal rhegmatogenous retinal detachment surgery, which is pneumoretinopexy, in which you inject the air will rise up and will push back the detached part of the retina. पढ़ा है ना? वहां पे SF6 is the most commonly gas used, but C3F8 is perfluoropropane. So this is the best gas which is used in your retinal detachment. So if there is detachment of the retina, so you put the gas and it will go up, and it will, because it is lighter than vitreous, it will rise, push back the detached part of retina. Now they are talking of intracameral. So what is the point of intracameral? Probably maybe there is some layered detachment which they are trying to repair. Okay, now coming back to the question, so they have specifically mentioned that the patient is having itching, astigmatism, chronic rubbing, so you know it is keratoconus. Have you ever heard of something known as walked striae in keratoconus? What are walked striae? Walked striae are stretch in the Descemet membrane, which may even lead to tears. Once it will get torn, it will lead to corneal edema, which will lead to loss of vision, right? So now I think you can connect the dots. If there is keratoconus, if there is tear in the Descemet membrane, you use C3F8 gas the moment you inject it in the anterior chamber. So this gas of course is lighter, so it will help in reattachment of the tear in the Descemet membrane, like it helped in the reattachment of your retina in rhegmatogenous retinal detachment. Okay, now why in keratoconus? Another important point I have discussed it in my classes, that what is the surgery if C3R fails? What is the best surgery for keratoconus? It is always optical keratoplasty, and because there is generalized thinning of the cornea, you always go for penetrating keratoplasty. So if there is penetrating keratoplasty, why you would only want to change Descemet's membrane when the entire cornea is thinned out? So you would not be able to go on for desec in keratoconus. You have the option of going on for penetrating keratoplasty, which is a very commonly done optical uh, keratoplasty surgery in keratoconus, right? But here you will go on for intracameral C3 F8 injection. And do you know, if you have attended my class on iCoach app or elsewhere, so you would have seen me injecting air while even doing cataract surgery. So I generally tell that in cataract surgery, once it is done, so it is always better to inject some air which will maintain the anterior chamber. And sometimes while doing cataract surgery, even if there is Descemet detachment, sometimes we inject air in the anterior chamber which will rise up and it will push back the detached layer of Descemet membrane, and it will help in recovering the Descemet detachment. So I am going to show you the end point of the surgery where everything is done and in the end the air is being injected in the anterior chamber. So you can see, so can you appreciate the air? This is just the room air. You take it in the syringe, you simply inject it. It will help in well maintaining of the anterior chamber for like around 12 to 24 hours. By the time the incision wound, the side port wound, they are healed. Okay, all right. So that is how the air is injected. So the answer is intracameral. Now if you did not know what to mark based on your educated guess, you could have marked it, है ना? But that's okay. Basic idea is to read everything in a quick detail, and also to learn how to mark MCQ. See, knowing the topic is one thing, but marking it correctly is entirely a different thing. For that you need practice. That is why I always say, no matter how much you have read, but it is very very important to practice daily MCQs, because that will teach you, that will train you to pick up the right answer, even if you haven't read the topic completely, or if there are some points which they have asked which are out of the box. Okay, now which of the following method is used to assess visual acuity in pre-verbal infant? Verbal, not able to speak, not able to kind of identify the letters which are written. So first is your ETDRS chart. ETDRS is early treatment diabetic retinopathy study. So this is a kind of log mar chart, and it is usually used in for scientific purposes, है ना, for doing any research work. And the important point about this chart is that it is read from 4-meter distance. Like Snellen's chart, it is read from 6 meters. ETDRS is read from 4-meter distance, right? Okay, and there is one chart which is Landolt C chart. This is for illiterate people, right? So who cannot identify AXO, HTV, UXAO, MXO, TUY like this. So you just ask, where do you see that a circle is cut? Of course it is C, but you ask, where do you see? So there are different lines. Top line 6 by 60, 6, 36, 24, 18, 12, 9, 6, even 5. है ना? If patient is having 6 by 5, it is better than normal. Okay, so that is for adults, so they are eliminated, right? But they have asked about pre-verbal infant. So one is your Teller chart. What happens in Teller chart? So there are multiple lines, so there are multiple charts which with decreasing of the distances between the multiple lines which are drawn. So these charts are shown to a pre-verbal infant, and based on the identification, so we can have the assessment of the visual acuity. And what is optokinetic nystagmus? So optokinetic nystagmus works on the basis of saccades and pursuit movements. So there is a black and white striped drum which is rotating. Wait, I am just going to show it to you. It will clear your concept. So this is your optokinetic drum which you can appreciate. Check this out. So you can see that there is a drum which is rotating, and the moment one black stripe is there, it is going. So I am focused on this black stripe. So the moment it will go rotate and go back, so I will shift my gaze to a new black stripe, back again black stripe, or vice versa, white stripe back, white stripe back. So the movements will be pursuit, saccades, pursuit, saccades, pursuit, saccade. So this is also your physiological nystagmus. Check this out. Can you appreciate your physiological nystagmus? Okay, this is your horizontal nystagmus. If you rotate it like this, there will be vertical nystagmus. You can appreciate. Can you appreciate? Okay, so if you rotate it in front of child, the child will automatically be fixated onto either black or white stripe, and you will know that the child is able to see that. So we know the answers are second and third. So what is the option? You will go for C option, and here you can appreciate the optokinetic drum, and here you can appreciate the different gratings on Teller chart. So here, it is like this. I hope it is clear, है ना? All right, let's move over to the next question. A 30-year-old contact lens wearer presents with severe pain, redness, ring-like lesion, keyword, watery discharge from the eye after 2 weeks. Okay, normally which is the most common organism associated with contact lens keratitis, boys and girls? This is simple, Pseudomonas. If there was no ring-like lesion, if in this image as well you see ring-like lesion, you would have gone on for Pseudomonas, and for Pseudomonas there is gram stain. Okay, Gomori methenamine silver stain is for fungus like Candida, Aspergillus, okay, Rhizopus. So watery discharge from the eye after 2 weeks. Now first you need to make the diagnosis. So based on ring-like lesion, ring ulcer, what is the diagnosis? It is acanthamoeba keratitis. But acanthamoeba keratitis, don't use gram stain, you don't use methenamine silver stain. Zn stain is for your tuberculosis, right? So calcofluor white stain is for your acanthamoeba. Mind you, if there is fungal keratitis, the signs are more than symptoms. If there is acanthamoeba keratitis, symptoms are more than signs. Why? Because this ulcer is very painful. Although it appears to be like just small ring, but it is very, very painful because of the involvement of the corneal nerves. It causes neuritis. The corneal subepithelial nerves are inflamed, perineuritis, right? But there is one important PYQ which was even asked in your FMG exam, and that is drug of choice in acanthamoeba keratitis. It is PHMB, polyhexamethyl biguanide. Very important. And symptoms are more than signs. There may even be presence of pseudodendrites. Pseudodendrites are there. Pseudodendrites. And acanthamoeba is usually more common in patients who have a history of washing contact lenses in tap water, or history of swimming in pond with contact lenses on, mind you. Okay, all right. Now which of the following is true for RB gene? So guys, this is the last question. So I could collect 7 questions, so I could not get the complete question. So some students, they told me that they had given an option that retinoblastoma is bilateral. Mind you, it can be unilateral and it can be bilateral. Unilateral is 70%, bilateral is 30%. And do you know, it can be hereditary, it can even be non-hereditary. Non-hereditary is your 94%, hereditary is your 6%. That is very important. And there is one gene which is RB gene which is present on 13q14. So Q is long arm and 13 means chromosome 13, 14 means band 14, right? So retinoblastoma is bilateral, eliminated. I am not sure of the remaining two options which I could not get from the students, but cancer causing gene due to loss of function are oncogenic. That is the correct option. So you must have heard about two hit hypothesis. Knudsen two hit hypothesis. Knudsen two hit hypothesis states that there has to be two hits on this RB gene so that the retinoblastoma could be expressed. If one hit is there, the patient will be called as carrier and the carriers will not have retinoblastoma. If two hits are there, then only retinoblastoma will happen. All right, so boys and girls, this was your all about INICET November 2025 paper. Do let me know how you like the discussion, and if you have any doubts, any queries, you can always follow me on Instagram. I_Manish is my Insta handle. You can also always WhatsApp me on this number. I will try to respond to you at earliest. Any of your doubts are most welcome. I wish you all the best for your INICET result. और अगर result थोड़ा left right आता है तो मन पे मत लेना. डोंट लेट इट अफेक्ट योर नीट पीजी प्रिपरेशन. नीट पीजी में बहुत ज़्यादा सीट्स होती हैं, बहुत हाई चांसेस होते हैं आपको अपनी ब्रांच ऑफ चॉइस मिलने के, कॉलेज ऑफ चॉइस मिलने के. सो डोंट सल्क ओवर इट. यहाँ पे अगर आपको आप बहुत अच्छा रैंक आ गया, आपको ब्रांच ऑफ चॉइस और कॉलेज ऑफ चॉइस मिल गया, डेफिनेटली गो फॉर इट. अगर कॉलेज ऑफ चॉइस नहीं मिल रहा हुआ, ब्रांच ऑफ चॉइस मिल रही हुई, तो एक बार मुझसे बात कर लेना. अगर कुछ डाउट्स हुए तो आई विल बी अवेलेबल फॉर यू ऑल द टाइम. और अगर कॉलेज ऑफ चॉइस नहीं मिल रहा हुआ, ब्रांच ऑफ चॉइस भी नहीं मिल रहा हुआ, फिर तो हमारे पास भी कोई चॉइस नहीं, हमने नीट पीजी 2026 देना ही है. सो विद दिस, बेस्ट विशेस फ्रॉम माई साइड एंड टेक केयर.